Okay, well, welcome everyone, excuse me, to the annual NIPN meeting. I am so excited to be here for my first meeting. For those of you who I have not yet had a chance to meet, I'm Rachel Garfield. I'm the Executive Director at VCHIP. I started back in February. And in the short time that I've been here at VCHIP and also been able to work with NIPN, it's just been so wonderful to be part of this very supportive, collaborative community. And I'm just really, really thrilled that we were able to bring everyone together today to share ideas and for a great afternoon of learning. Hopefully everyone has had a chance to share their sheep state with us today. We're going to do more formal introductions. If you want to take a minute to just put into the chat a brief introduction of yourself, because we are expecting a relatively large number of people today. Just go ahead and introduce yourself in the chat with your name, your IP or organization that you're coming from, what state you're in if it's not clear from your IP name, and also your role that you're playing within that IP. And I know a lot of you already know each other, so for those of us who are new, it will be great to kind of have that. I did want to take a minute to introduce a new face here at VCHIP, who is Christy Galise. Christy, you can wave. Our new assistant director at VCHIP, who's also helping us out with a lot of the NIPN related work as well. So for those of you who haven't had a chance to meet Christy yet, I'm sure you will in the upcoming months. While we had originally hoped to see many of you in person, I'm really glad we were able to course correct to bring so many people together in this Zoom room. Remains to be seen about whether virtual is sort of our standard state moving forward, but for now, we're excited to leverage the advantages of the technology and be able to include many people who otherwise wouldn't have been able to make the trip to join us today. So we know it's a long afternoon on Zoom. We've worked in some breaks, and of course, people can feel free to take breaks as they need to throughout the day. We have an exciting afternoon or morning, depending on where you are, morning to afternoon planned. And we've actually been able to keep a lot of our originally planned agenda items. Unfortunately, minus Christy Faye's Fabulous Cookies, which I know many of you have enjoyed in the past. But we have kind of a packed day, a mix of presentations and interactive sessions. So after this welcome introductions, we're going to have a presentation on trends in child health, which I'll introduce more fully in just a moment. That will lead into some breakout groups that we're hoping to have a lot of really fantastic discussion on 2 different topics, and you can choose which group is better suited to your interests. We'll take a break, a short break, allow people to stretch their legs, get a drink, bio break, whatever is needed. And then we're going to hear from Dr. Wendy Davis on anti-racist medicine and QI. And that presentation is going to set us up for our second round of breakout groups, in which we're really going to take the information that's presented and try to do some action items of what we can take away from that. We'll wrap up with just a brief, wrap up of the day. And then go from there. So hopefully we'll have a lot of discussion, and we really hope to hear from everyone. So that'll be fantastic. Just a few housekeeping items before we dive in to things. Please use the chat to type questions, comments, or feedback. We will be monitoring the chat throughout the presentations and breakout sessions. So it's a great way to ask questions or get clarification on anything you need. For those of you who are not familiar with the chat function in Zoom, you can click on the chat icon below and just type in your question. Everyone should be automatically on mute, and we ask that you stay on mute when others are presenting. But then, of course, for the discussion, feel free to come off of mute as well. And if people want to keep their cameras on, that's great. It's a great way for us to kind of feel a little bit more like we're together versus just looking at some black boxes. If anyone is having technical problems, Christy Faye is on hand to help you troubleshoot, and her email address is right there. We are also offering live captioning for this. If anyone needs that, there's some instructions there about how you can access that. And again, if we're going too fast and you need to get back to that information, just shoot us a message in the chat and we'll make sure that you have the information that you need. Next slide, Rachel. And as I said, we're going to have a 15-minute break at the midpoint. People can, obviously take a break as they need throughout the day, excuse me, throughout the afternoon. But we have built in a little bit of time because we realize that is quite a long time to sit and stare at a computer screen. And I think with that, are we moving into the next thing? Great. So before we dive into our main content of our first session, we're going to do a quick poll that Rachel WB is going to Rachel Wallace-Brodeur, sorry, using V-tip nicknames, is going to walk us through just so we can make sure everyone knows each other. So I will pass it off to you, Rachel.
Thank you, Rachel, and hello, everyone. Really exciting to be with you and see you all today. And we were joking about the sheet scale yesterday, how we've never seen anyone put a 9, and it was so exciting to see so many 9s, people being excited, and I am definitely a 9 because I am thrilled to be with you all. So yes, we're going to do some rapid fire polls, just since we can't be together. We'll get a sense of who actually is here. So get your mouth ready because I'm not going to wait 30 seconds. It's going to be more like 10 seconds. All right. So first one, we want to know where folks are joining from today. So just select where you're at so we can get a sense of where we all are. Okay. All right, we got a lot of Northwest folks, but nice to see folks from everywhere. Okay. Then I have a few just fun this or that. So don't overthink this. First one, for sports, people in the sports, you might notice there's a World Cup going on in soccer. And I noticed Saturday there was a little competition between the NFL and FIFA. So put in where you're at, soccer or football. And I'm not asking what you call soccer, because I know that's a knife that's been around. All right, very interesting. Soccer went out, and that's definitely what's happening in our house for sure. My daughter is very into soccer, and I've gotten into it. All right, hopefully this is easy. What's your drink of choice, coffee or tea? All right, overwhelming support in the coffee area. So when we have the break, those of you who need your coffee can pop right out and get that. All right, we got just 2 more quick ones. All right, for vacation, are you someone who's going to the city to get a little culture, or are you getting outdoors in nature, doing some camping or hiking? All right. Looks like we have a bunch of nature goers here. Nice. All right. And our last one is this the first time you are attending a NIPN annual meeting? You might have done other NIPN events, but is this your first NIPN annual? All right, well, it's super exciting to see so many new people here. We actually have more people attending for the first time than have been here before. And we are so happy to have you all here and so happy to see, both new and familiar faces. So without further ado, let's get started on our day.
Thanks, Rachel. I want to echo, it's so great to see so many new faces. I am, of course, one of the new faces, but it's really exciting to see so much excitement and enthusiasm for the meeting today. So thank you to everyone. So we are going to dive in and get going. We are going to start with a presentation on the National Survey of Children's Health that will not only review recent trends in child health, but will also talk about some of the data that underpins our work and how we can leverage that data. And we're really excited to have Dr. Reem Gondor from HRSA here today to share her knowledge with us. She is the director of the Division of Epidemiology within the Maternal and Child Health Bureau's Office of Epidemiology and Research. She oversees a range of programming investments designed to extend and enhance data, analytic, performance measurement, and evaluation capacity at both the state and national levels. And in this capacity has directed the National Survey of Children's Health since 2013. Dr. Gondor holds a DRPH from the Johns Hopkins Bloomberg School of Public Health and an MPA from the Maxwell School of Citizenship and Public Affairs at Syracuse University. And notably in 2021, she received the Samuel J. Heyman Service to America Medal for Science and Environment for her work to transform the National Survey of Children's Health. So with that, I will turn it over to you.
Thank you so much, Rachel. First, let me just make sure everybody can hear me okay. Okay, awesome. And now the next part of the challenge, can I effectively share my screen? Let's see. Okay. And I believe you are. I can switch this to presentation mode. Okay, this worked. This is very, very exciting. 2 years into the pandemic, I've finally figured out how to do this. So first of all, thank you so much for the invitation to be here today. This is my first NIPN meeting. So I'm glad to see that I'm in good company. But I do want to say that I hope this is not a one and done, because I really love the opportunity to connect with our data users. This is not a survey that's just done for the sake of getting some data or for research. Our survey is really designed to be user-friendly, but also value-added to what folks are doing at the state, local, and national level. So please feel free to interrupt me, and happy to do more Q&A after the presentation. But most certainly, if something really stands out for you, please feel free to follow up afterwards. I'd love to hear your thoughts and your reactions. So to that end, I'm going to try to do 3 things in 45 minutes. And hopefully leave plenty of time for discussion. So I am going to do a brief overview of the NSCH just to do some level setting. Some of you may be old time users, some of you not so much. So I just want to make sure we're all talking about the same thing. The bulk of the presentation is going to be presenting estimates from our latest 2-year estimates from 2021 data, as well as some of our trend data starting in 2016. And then I'll move into a little bit more about what's coming up. So you'll get a sneak peek into what'll be some new content areas in the next couple of years, as well as some of the work we're doing to make these data even more relevant for states. And then a little bit of information about our longitudinal cohort survey that'll be coming out in the next couple of years. So that's the game plan for today. And let me start with a brief overview of the survey. So the National Survey of Children's Health is actually a longstanding investment from HRSA. Our first survey was fielded in 2001, and you might have known that version as the National Survey of Children with Special Healthcare Needs. We followed a couple years later in 2003 with the first National Survey of Children's Health, and then we alternated for about a decade and a half, doing each one of those surveys every 2 years. That was lovely, except it really meant that folks were waiting 4 years for new data every time they wanted to do, some additional or new decision making. And so we did a complete overhaul in 2016. So the survey is now annual. It remains cross-sectional, but we are now an address-based survey. So we used to be a telephone survey. As I'm sure many of you know, people no longer pick up landlines. They don't even really pick up cell phones. So we had to make an adjustment. So we're now address-based, and most of the data are collected via the web, although we certainly offer folks the opportunity to participate via paper and pencil. We still collect data on a whole lot of content, which I'll show you in a minute. for kids 0 to 17. And we still provide both national and state level data. And that's that state level data piece that I think is probably most relevant for most of you. We do release data annually on Child Health Day. So that's the first Monday in October. So we come out of the field in January and we release the next October. So it's pretty rapid given the size of the sample that we work with. For those of you, and I suspect there's a lot of you in this audience who really like to get into the nitty-gritty, I will spare you the deep dive into our methods, but just a couple of points that might be of interest to you. Again, it is a multi-mode design with about 70% of our households getting what we call a web push. So they're really being invited to participate by web. Ultimately, about 70 to 80% of our households do participate via web. It is two-stage, so we have a screener that goes out that does a very sort of brief census of kids, and then it's followed directly by an age-specific topical questionnaire, and that is for one randomly selected child. If you participate via the web, this is super seamless. You do your screener, and the Centurion system at census just bumps you into an age-appropriate topical. If it's paper and pencil, you can imagine you mail it back, we mail you another survey, and that, you know, completes your experience. In terms of our sample size and response rates, you can see here from 2016 to 2021, it's varied. The variation is really just a result of funding. It's how much money we can at the federal level kind of turn around and get out the door to support sample. And, you know, altogether, we are moving towards a space where I think for the next at least year or two, we're going to have samples at least over 50,000. You combine all of that and you've got 225,000 kids you can run your data on at the national level. Obviously, that's much smaller at the state level, but we do try to always hit a certain, at least a floor across the nation where every state has at least a base level of participation. Some states participate at higher rates than others. So we do send a lot more mail out to Alabama than we do Wisconsin, but we have a commitment to our Title V partners to make sure that we get at least a minimum across the nation. Our overall response rate is around 40%, give or take. And then we have an interview completion rate of close to 80%. And that just means like once folks get into the survey, 80% of them actually complete it. And this, I'm going to jump into a couple of slides that just kind of talk about the utility of the survey and where I think there's probably the most connection to at least some of the work that you're doing is that we serve as the primary data source for the Title V Maternal and Child Services Block Grant performance and outcome measures. We serve as the data source for 20 of them. Which are listed here. And I actually have run charts on all of these later in the presentation if you want to see those. We also are the data source for healthy people objectives. We are the data source on kids with special healthcare needs. And then we also inform both CDC particularly, but also other MCHB investments around early childhood. We're also obviously used in research. So I had the good fortune of doing a 5-year trends paper in JAMA Peds this year with one of my colleagues that really helped to highlight especially some of the challenges around mental health. But we're also a data source that partners with a number of other organizations like RWJF to do the State of Childhood Obesity Report, Americans Health Rankings, Kids Count, things like that. So a lot of folks use our data. We try to partner with them to make sure that we're all sort of presenting and talking about things, you know, in a consistent manner. But in other times, our data are picked up and we don't even know about it. And we learn about it along with everybody else when CNN covers, you know, a Starbucks personnel decision based on our data. So we're just thrilled that folks are using it. And we always want to make sure that especially folks at the state level have access and that it's useful to you all. So I hope you will give us some of that feedback as well as we get through this. This is one of the reasons why the data is, I think, used as broadly as it is that we really cover the waterfront on kids' health. And I'm going to dig into hopefully some piece of all of this in my presentation and give you a snapshot of it. But we cover content in 8 core areas for all ages of kids, and you can see those here. And then for the very youngest kids, we also have content around healthy and ready to learn. And I'll tell you a little bit more about when you'll be getting those estimates at the state level. And then for older kids, we have content around healthcare transition planning. All of our data are parent or caregiver report. So when you're talking about health status and activities, it's parents reporting on whether or not their child received a diagnosis of, so whether or not a healthcare provider told them that their child had a particular condition. For our other items, especially around healthcare access and utilization, and then especially some of the more subjective measures that might go into medical home or insurance adequacy, these are all what parents and caregivers say they are experiencing in the healthcare setting. So these aren't, while all of our content is cognitively tested and almost annually, it's not the same as sort of doing a comparison against medical records. So that's always a tension that we have. But because we're doing parent report, we're really we're able to collect data on a very wide range of areas. So unless there's any questions on methods, I'll jump right into the estimates. I'm not seeing any. Okay, so let's get right into the key estimates. So one of the things, as I mentioned, we do collect data on a variety of different health conditions. We ask parents about 25 or so diagnosed conditions. And these are either current or lifelong health conditions. This slide just presents, the most common among kids 3 to 17. And consistent with most years, allergies are the most commonly reported condition, followed by ADHD and anxiety. Unfortunately, also consistent with previous years that I've done this presentation, the majority of the 12 most frequently reported conditions are mental, behavioral, and developmental conditions. Because we have state level data, we can do these kinds of maps. So we specifically looked at ADHD, which is a national outcome measure for Title V. Nationally, just under 10% of kids have diagnosed ADHD, and it obviously has a very significant range from just under 5% in California to a little over 15% in Louisiana. The way the coding is, so the lightest shade of pink is those with the lowest prevalence to the highest or the darkest shade, which is in Louisiana. Overall, 13 states had rates that were significantly higher than the national overall, and 10 states had lower, significantly lower rates. As I mentioned, we are the primary data source for children with special healthcare needs. We identify kids using the 5-item CSHCN screener. I suspect I'm sort of preaching to the choir here, but I like to use this slide in particular because I think it really highlights that while we can give overarching statistics like 1 in 5 children in this country have a special healthcare need, or 30% of households are supporting a SHIN, this is really a very heterogeneous population with a wide variety of needs and impacts. And so when you think about how Title V and states are really trying to meet the needs of this population and their families, it can really run the gamut in terms of what folks could do. So we see here that it's about a roughly even split in terms of the type of special healthcare need. But we also see that the majority of kids are either never affected or sometimes immoderately impacted. That's not to discount, the 1/6 that are dealing with consistent or significant impacts, but it does suggest that something may be working in terms of helping to reduce the limitations associated with some of these conditions. When we map that, again, it is a pretty wide variation. We always struggle with this as a measure because, who's to say this is a bad measure or a good measure if you're going up or going down? What I think it's, signifies to me is that you have parents who are reflecting on the impacts that their child's condition has on their family and on the child. And that is what they are reporting. So having a higher rate, higher prevalence of special healthcare needs in any given state simply tells me that there are parents in that state who are certainly feeling the impacts of those special healthcare needs, perhaps more strongly than they are in other states. And you can kind of peel that back and try to see what is it about the state policies or the state programs that might be driving that experience. We do, for at least a handful of our conditions, try to dig in a little deeper into kind of the kinds of treatments that kids are having or getting access to. This is actually content that we add with support from the Centers for Disease Control. And excuse me, for both ADHD and autism, currently diagnosed conditions, we ask parents whether or not kids are receiving behavioral treatment and whether or not they're receiving medication treatment, and we do that separately. I always think this is I'm not obviously a physician by training, but I always think particularly the ADHD numbers are really striking to me, because we know that at least for ADHD, behavioral treatment should be the first line of defense. And so it's striking to me that still closer to 60% of kids are being treated with medication, when a lower percentage are actually getting that behavioral treatment, and even lower than that, less than 1/3 are getting both. I think we can certainly look at this by age and some other demographic factors, but this is one of those sort of places where I always wonder if we could or should be doing more. In terms of healthcare quality, one of our primary measures that we look at is medical home access. It's a Title V performance measure. It's also one of the measures that our Division of Services for Children with Special Healthcare Needs puts a lot of investment toward. And as a nation, we have a long way to go here. Only 46.6% of kids have access to a medical home. Now, there's about 30 some odd questions in the survey that actually go into measuring medical home. And it ranges everything from having, a personal doctor or nurse to really thinking about whether or not you receive family-centered care. Now, those are pretty disparate when you think about how parents are going to be reporting that. I can tell you from having looked at these data more closely over time that the biggest drivers of disparity are around care coordination. So kids who often need the most care coordination are the ones who are least likely to get it, and around referral access. That's another one that it's a big driver. So, I think I presented them here by demographics just to kind of give you a sense of what we can do with the data. But I think if you're really interested in medical home, and that's an area where your state might be really looking to make improvements, it's usually not around having a personal doctor or nurse or having a usual source of care. It's really some of those sort of deeper care measures where you see that families are not necessarily getting their needs met. We did map medical home access. Again, you see that nationwide estimate of just under 50%, but you also see a great deal of variation across the states, with a low of 34.7% in Nevada up to over 50% in New Hampshire. Developmental screening is another measure. It's a Title V performance measure, but it is also a performance measure for our home visiting programs. So this is one that we pay a lot of attention to. In 2020, 2021, only about 1 in 3 kids who were 9 to 35 months had received a parent-reported or parent-completed developmental screening from a healthcare professional. So I want to be clear about that. So this is like ages and stages, something like that. The parent went into the well child visit and remembered completing one of these screens. The estimate ranges, again, pretty significantly from just under 1 in 5 in Arizona to over 50% in Oregon. Overall, 8 states were significantly higher than the nation overall, and 8 states were significantly lower. And you can kind of see that across in the lighter blue and the darker blue. We know that when this particular behavior or experience is targeted. So for example, in our home visiting programs where it's like it's a component of what the home visitors are providing, or at least talking to parents about, that this can go all the way up to 70 or 80% in a program setting where this is targeted. So it's not that this can't happen, it's just that it's not happening sort of routinely or in a way that parents are connecting with it as an actual developmental screen. And the last kind of healthcare quality measure I wanted to highlight for you, we do ask parents about foregone care. We ask them about a range of different types of care. And this is actually, interestingly to us, and we continue to kind of dig into this, is that only about 3.8% of kids are reported to have had truly foregone care. And I don't mean delayed care, but we asked them very deliberately, like they did not end up receiving care. And that ranges from a low of 2% in Nebraska to just under 6% in New Mexico. You know, I don't know that I call this a win just yet. Maybe it is reflective of kids, a relatively high number of kids having access to some kind of usual source of care. It may be reflective that of the fact that the vast majority of kids are actually in relatively good health. But I also think it may be reflective of what parents' own experiences with the healthcare system might be and what their expectations of healthcare might be. They may not know that they are missing out on something if it really hasn't been explained to them or it isn't part of their own experience. So I always treat these data in particular very carefully, and I want to caveat them that when we present them. So this is a new measure that we have access to. Next couple of slides are just focusing on data that are new data in 2021. And I want to, like, amongst friends, stamp draft all over this because we're still thinking through how best to present this. We had a pretty significant influx of funds from the nutrition folks at CDC to ask parents about nutrition, so specifically vegetable consumption, fruit consumption, sugary drink consumption, and then outdoor play among kids 0 to 5. And we asked it of 0 to 5, but we're really only looking at it 1 to 5. And we decided inside the Bureau that, well, wouldn't it be cool to kind of think about this as that AAP, like, the 5 to 1 0 measure, and then also think about building in some sleep in there, really thinking about that spectrum of modifiable healthy weight behaviors. We've just started running the data, and this is what we're seeing here. So just under 40% of kids getting 3 or more fruits or vegetables on an average day, 75% having two hours or less of screen time, outdoor play, less of an issue, which is great, but you still have about a third of kids, only a third of kids having 0 sugary drinks. And then, just under 2/3 getting 10 or more hours of sleep. So I think we're spending some time talking to the folks at NHANES who actually do the, sort of dietary recall, as well as some folks in the nutrition center trying to figure out, like, what's the best way to frame this. But we really wanted to ultimately give parents as well as states, something that was simple that we could all sort of, get our heads around in terms of that, like, spectrum of behaviors that we would like young children to be engaging in to the extent that they can. The next two slides are focusing on adverse childhood experiences. This is a very significant area of interest in the Bureau, is looking at some of these upstream upstream determinants of health. And our survey asks about 11 adverse childhood experiences. Yes, these are parent report. So we know that's a limitation, but it's also the only place where you can get data for younger kids on most of these measures. So YRBSS does have data on some adverse childhood experiences, but again, those are high school kids for the most part. So what's new in 2021 is that we added an item on discrimination due to disability or a health condition. So that we have now 3 items on discrimination, one related to gender identity and sexual orientation, and another that's been longstanding on race and ethnicity. Here that you see the prevalence of these in descending order. Obviously, parent divorced or separated is the most commonly reported measure, but not insignificant proportions of kids have experienced some of these other sort of very challenging impacts. And when, just to give you a sneak peek, we have certainly looked at the racial discrimination item, and there are some really big differences. So both Black, non-Hispanic, and Asian American, American Indian, Alaska Native kids, about 13% of them are reported to have experienced discrimination, compared to about 1% of most other kids. And then almost 14% of children with special healthcare needs reported that, or their parents reported that they had experienced discrimination due to their health condition. So I always think about these as, this is important. These discrimination items are particularly important when we're thinking about serving these kids in the long haul. Oftentimes they're grappling with so much more than a particular condition or set of conditions. They're also grappling with all the social effects and impacts of either a condition or any other piece. And then you combine these things together, as we do in the next slide, and you look at the proportion of kids who've experienced 2 or more adverse experiences, and we're at 17.2% nationwide. That's 1/5 of kids who've experienced at least 2 of those events. So even if you're kind of discounting divorce or separation, and you're looking at all these other pieces, I mean, that will have a long-term impact on our pediatric population. In 2021, we added content on COVID impacts as we needed to. And so we kept that content for 2022. So we'll have 1 more year of that. We are going to drop it in the future. I mean, assuming things continue in the track that they're going in terms of the pandemic. We did see that, at least in terms of missed preventive visits, and I'm going to show you some trend data on that in a minute, kids with special healthcare needs fared worse. So about 36% of those kids missed or delayed a preventive checkup. But on the flip side, kids with special healthcare needs were much more likely to receive telehealth. So some kind of, silver lining there, that and hopefully, just like this meeting is going virtual, hopefully we can continue to build on that capacity and make sure that the kids who may need it the most still have access to the healthcare and guidance that they need. So I will wrap up the data portion of the presentation, just going through some of our trend estimates that we're able to pull now with 6 years of data. I have to say, when we ran these particular estimates, it was pretty depressing because I think we all thought, when we saw that big dip in 2020, that we were going to see a bounce up in 2021, and it just hasn't materialized yet. So now maybe that's a function of when we were in the field, which is roughly June to January, but it's, I'm still hoping for a bounce up. Then again, maybe these have been replaced by some telehealth. I don't know, but you like to think that these kids are actually getting into a doctor's office, getting their vaccines, et cetera. So something to keep an eye on there for sure. We also continue to watch mental health conditions. So this was something we reported in the JAMA Peds article. We've extended it for you guys to show the additional year of data. So unfortunately, anxiety and depression both increased a little over 30% since 2016. So these were on the rise, and now you've got the pandemic hitting and the impacts of that. And I don't know that we're making progress there. Behavior and conduct, interestingly, there was a blip, as you can see, in 2020, and now that has come back down now. So at least as far as that one piece of this pie, we may not be as concerned. But again, I think the depression and anxiety is one that we are not rid of by any stretch. And this is another sort of side of that. When you think about kind of the context in which kids are experiencing their own mental health challenges, it's not just them, it's their parents. I bet there's a lot of parents in this meeting right now who can tell you it kind of becomes a family thing when you're really struggling. And so we've seen a pretty steady decrease in the proportion of parents that are reporting that they are in excellent and very good health, and that they're coping well, very well, with parenting demand. So it's about a 9% decline overall during the life of the survey. So this is actually an area where I think we're going to start to do a little more work, because we know that 2-generational interventions are often the most successful for some of the most challenging child health issues. I want to be conscious of time. So for those of you who are tracking to Title V, so for both our performance measures and our outcome measures in the next slide, I just wanted to include run charts and kind of a quick glance at where we are doing nationally. And we've had improvements in developmental screening, bullying and healthcare transition planning, and smoking in the home, but also a number of notable worsening indicators over time. And then significant worsening in our outcome measures, systems of care, foregone care, and an increase in autism. All of these data are available at the state level. So if this is something you want to look at any of these specifically for your state, I can help you do that. So let me turn now just to present a couple of sneak peeks at where we are going. One of the things we've been offering since 2020 is the option for states to purchase oversamples. I suspect some of your states have done this. A lot of states are doing it either because they want to really focus on just boosting their sample overall so they can do more robust analyses of particular populations. The other option is to do it in such a way that you are then able to get access to sub-state level data, because we know a lot of decisions are made at a county level, at a regional level within a state. So that's another option. The costs, as you can see, have ranged everywhere from $20,000 to $500,000. We've worked with states kind of across that spectrum. And generally, we finalize plans for this in the summer before we actually go into the field. So it's a little tough from a budgeting standpoint, and we know that with states, but we've come up with a couple of different options to help folks pay for it. This is a map. So you might see your state on there. If you have a specific question about an oversample, I'm happy to put you in touch with Dr. Ashley Harai, who has really been working with states individually. But overall, we started with 4 states. We're now up to 15 states and Metro Atlanta. And the majority of our states, as you can see here, are really focused on getting more detailed race and ethnicity data. There is a link here if you want to dive more into oversampling. We have actually a pretty comprehensive kind of how-to that you're welcome to look at. So where are we going? So 2022 is in the field. We started July 8th. We're expecting about 53,000 to 55,000 completed interviews, and the data will be released next October. What I'm really excited about in this new wave of data collection is that we have a new item on housing instability, which we think is pretty critical as a social determinant of health. We'll also have a new item on eating, sort of disordered eating behaviors. And something that's very near and dear to my heart is that we finally have the final set of 29 items that will be used to assess school readiness, and we'll be releasing both state and national estimates on that in October. So if you're interested in that content, that new content, I've included it here. All of our questionnaires are publicly available online, so you can also go look at them in English and Spanish if you wish. So that was the housing. This is eating one weight-related behavior. And then this is a little bit more background on healthy and ready to learn. We are covering, again, 29 items in these 5 domains, and this will be for 3 to 5-year-olds. And this is just a little bit about the data availability. So you can always download the full microfile and analyze it yourself. We'll have Metro Atlanta available for that one. You can also request special access through the Census Bureau's research data centers if you want to do anything that is at a geographic level below the state level. And then the last thing I wanted to cover is our longitudinal cohort. So one of the things we decided to do, since we're super lucky to have data from kids prior to the pandemic, is we are following back families that responded to the 2018 and 2019 NSCH to find out how kids are doing post-pandemic. And this is really where we're going to be focusing. Any disruptions they had around childcare and school, especially disruptions to services that they might have needed if they were a child with a learning difference or a special healthcare need, their access to healthcare, mental health is going to be a big component, as well as economic hardship. And as I said, we're now also going to be, since we're following up all those kids, some of them will be actually 18 to 22, and this is our first chance, and we have to add content specifically around the receipt of healthcare transition. So not just did you plan for it, but did you actually get it? And it'll be similarly web and paper. We will go into the field next summer, and then the data will be released at the national and state level in the fall of 2024. So just closing up now with how you get to the data, we take a no wrong door approach. So you can either go to our website, which is there, and there'll be links to everything. You can go straight to the Census Bureau's website. You can download all of the data files from all of the years, the methodology reports, all sorts of documents from Census that you may never want to read, but just in case you do. And then you can also go to our data resource center, which is basically how we make the data publicly available to anyone, whether you run data or not. And this is what it looks like. You can actually go run pretty much every estimate that I shared with you today for your state and by whatever stratifiers you might be interested in. And it'll pop out a nice graph and a table. So all of that is available to you. And clearly, I need to be super clear, none of this would happen without an amazing team. So we have really an astounding group of folks who love this survey and love this work. And, you know, some of them have special expertise and might be willing to and able to consult with you if you have a particular question or analytic issue. And I'm going to stop sharing and open it up for questions.
Thank you so much, Dr. Gandor. This is Brina Holmes. And those of you outside of Vermont don't know, but I have a chat title. I'm often the person that does the chat in our community practice calls we do with our field. And so that's what I'm going to do today. So some of these came in back at the beginning and I hesitated to interrupt, but I'm so sorry. Contextualize. Okay. There were a few questions at the beginning. Hold 1 second. So Peggy wants to know, when you see data like the ADHD data, what can you take from it? It's hard to believe there's that much variation across states.
That's a good question. Well, I don't doubt that there's that much variation, but I do think it might be driven by different factors. You know, we know that in some places, pediatricians are doing more diagnosis of ADHD and behavioral conditions. It could be that there's different practices or payment policies, what have you, different coverage of kids. If there are more kids in CHIP or Medicaid or something like that, they could be getting access to more diagnostic services that could be driving some of it. I'm pulling up the map now. So I don't know that it's a false aspect of the data, but I think it is more reflective of who's actually getting diagnosed, and what are their paths to diagnoses. So that's what I take away from that. I wouldn't necessarily go out and say, oh, Louisiana is, you know, in the pits, but I would probably want to go out and say, okay, how does their structure for services, especially behavioral or mental health services, differ from what's happening in a similar state? So what's happening in Mississippi and Alabama or something like that, not necessarily comparing them to California.
Yeah, and this is Peggy. So I think, sorry, let me flip my camera on. So I think that one of the things that it strikes me is, if we're sitting here thinking about how are we going to reduce the variation in care using measurable improvement, like those numbers, I look at it and I say, I don't know what to make from it, other than as a system, we're doing a terrible job measuring. Like whether it's how we're like measuring in a state, how we're delivering, how do we collect the data, how do we report it, how do we talk with families so that they have the ability to kind of, you know, communicate through different aspects. And I'm from Arizona, I'm in Arizona, and, you know, we don't have the best system for sure, but it just does not strike me that those numbers reflect sort of the experiences and realities of, you know, like for the schools that we're working with and things like that. So it's just really interesting. But what that says to me is, right now, the system, we're, as a system across the country, we're broken. You know, how do we standardize the criteria? Alex had pointed that out to me in the chat. You know, how do we do a better job so that we can then get a better sense of what's going on actually with the people we're trying to, you know, care for.
I mean, I think there are certainly differences in how, certainly in how parents are going to either want or not want to report a condition like that. Any condition, really. I mean, we do test these items with a variety of different respondents. The ADHD items have been on there for 20 plus years. So I'd also wonder, like, what if you're, yes, you want to know what's going on with the reporting and how families are perceiving that kind of question. But I think you also want to look at, well, how's the overall health status in a place? If you see, like in Louisiana, that has the highest rate, what's the health status? What are other health indicators of kids in Louisiana? Like, does it track? Does it make sense? Does it not make sense? Where do we think those kids are getting their care and getting that kind of diagnosis? So I think there's probably a lot of factors. And then I think in general, it's important to not just look at any of these health conditions just blank, you know, just as they are. You want to do stratification and look at them by different, by other measures. So, you know, how does that differ by medical home status? How does that differ by SHIN status overall? How does that differ by insurance status? So I think it's a complex picture in every state. So that would be my take home, is that what I've presented here is for an audience coming from lots of different places, but we would generally not make a single statement just based on, you know, as any of us would with one estimate. You'd want to look at the complexity of it.
Yeah. Well, I'll just add, as we move to the next question, that Peggy, there's clinical care data about ADHD that's fascinating. You can do prescribing data, which is not diagnosis, because not all children with ADHD get prescribed a stimulant, but there's massive variation in the prescribing data of stimulants around this country. So that's another trickle layer. Okay, so Angela wants to know, how does that 34.8% developmental screening rate or percentage compare to the last time you did it?
Now I saw your chart. You shared the chart later, the summary of all the measures. That's awesome.
Yeah.
Can you talk about the dip? So what is it? 21, it was, or 20, it was 36.9, and then most recently 34.8. Could that be COVID related?
Yes,
Thanks.
I would think so.
Okay. And then the last question, and then we're super happy to open up to verbal questions as well, small group or not so small, but intimate. Rachel wants to know, from the preventive healthcare services, do you have age stratified data on that?
Yeah, absolutely. So you could do anything that I showed you. You can run by single year, you can run by age groups. Yes, all of those things are possible.
Great. Okay, well, it's 1:58. I'm looking to my team. I think we probably have time for one more question if someone wants to.
Yeah, I think Colleen has her hand up.
Oh, thank you. Colleen.
Hi, I'm Colleen. I'm from Oregon, but I spent the first 15 years of my career at the CAMI. So cognitive testing on some of the NSETCH items myself. I had two different questions. So one is, as you're watching things track, for NIPN, one of the things that I think we're really good at is like pulling together public-private stakeholders to improve the health of children. And so taking a population-based approach while trying to think about what levers the systems have. And so one huge lever is obviously Medicaid and Medicaid requirements, and how we speak in a way that Medicaid can understand, and a way that Medicaid can use a lever that they have to push on quality. And so I'm wondering, my first question, and then I'll go to my second, just a curiosity, is have you tracked the metrics that we capture at a parent report? The correlation between those metrics and the pressure of core measure reporting? Because in my state, for example, there were a ton of us working on developmental screening, doing trainings, doing this. Our public health does a great job for the 7%, 10% of kids who get home visiting. So that's not going to move you at a state level. But amazingly, when we developed, and OPIP did, a metric that the healthcare system could use using claims data, because that's the lever that they have with who they contract with, and tied money to it. Like you just showed, Oregon's the top state. Before we had that, we've had NSETCH data for years. Like I've been trying to pound on it, but it was when we made it a contractual requirement that tied a lot of money to it. Oregon went from the bottom, which is where we were in 2013, to the top, which is what you showed. And so that hydraulic of like, how do you use population data, which is what I loved about your presentation of like the need, but then the hydraulic of like, actually, how do you think about metrics that push on levers within systems? I think that's where there's as a person who's been in all sides of the court, that's where there's this tension, because we can't use it from a contracting value-based payment point of view. So I'm curious, in terms of playing out that game, when you look at the NSETCH measures that have improved, how many of them align with the core measure reporting? Because I think some of my concern about where we're going with the core measure reporting, and even my state where we're going, is that that some of the populations you just noted that I'm most worried about, there's no metrics in the core measure set around that. So when we think about the lever that Medicaid plays, and Oregon has demonstrated, has played in a national survey. So one, have you done that crosswalk?
Yeah.
And then two, is there some behind the scenes thinking around that, given the hydraulic that needs to happen between those two parts?
That's an excellent point. And what I can say is that behind the scenes, I've probably talked to people at CMS, Centers for Medicare and Medicaid, 10, 15 times over my 20-year career in the federal government, and especially more in the last, 10 years since I've been running the survey. And we just never seem to it's like, I don't know how to create a meaningful connection there. The one thing I can say that maybe could maybe teeny tiny nudge on it is that with that longitudinal cohort that I mentioned, we have gotten funding and support to do a data linkage to Medicaid with the kids that we're following back on. I am hoping that that will then shine a light on some places where the Medicaid experience actually really helped some kids weather all of the crap that went along with the pandemic, because they got XYZ that other kids didn't, that like other kids who, so that might be a first moment, but that was something we crafted out of, because we have a new analyst who's like, I want to do data linkage. And so she like went down that path. The normal knocking on the CMS door has not been successful. So small ray of hope, and you raise a really good point. What's your other question?
Well, my other thing that I just wanted to share, and there's a bunch of NIPN states who are doing this, so that's why I promise not to be self-serving. But so I was on the CAMI team when we developed the screener. So the screener is parent report around impact, limitations and impact. And the original reason we did that is like when you looked at claims data, we were getting under rates, and you weren't getting it aligned with the Maternal and Child Health Bureau definition of children with special healthcare needs. And then to the point of our previous conversation, I'm 24 years in, and I'm like, we don't have systems that serve children and youth with special healthcare needs. And largely that is healthcare systems that have jobs to do that. I mean, in my state, they're getting a global budget to do that, and they don't focus on children with special healthcare needs. And the reason they don't is they don't have indicators to do so. They can't use the national survey for that because that's not at their contracting level. So I'm like perseverating on this. So a bunch of us have been trying to think about like, how do we get them data indicators at the unit of analysis by which they contract and for the population that they contract, because samples, our state has been doing the CAPS children with special health needs screener for years, and we can't, it's too small. They won't do it. It's hard to. And so what's so fascinating is there's a group of us that have we've all taken models to look at like, how do we measure within Medicaid, the medical complexity. So trying to align with children with special healthcare needs, but using data, and then some of us social complexity. But just one thing to share. So my whole career, I've always heard this 20% of children, 20% of children, 20% of children, which in itself should make our systems like care a little bit more, where you're like, it's 1 in 5 kids, folks. But what's super interesting is like, we've used the all payer, all claims. And in Oregon, it's 33% that have had medical services that indicate. So to me, I'm always like, that's an under report, because that's people who could access, but it is like 13% higher than these, like within the systems that have accountability. And then like, I know Vermont has run it, and Vermont's getting like a 24%. New Jersey is running it. They're getting a little bit higher. So just as we're thinking about this maternal and child health focus and how we all use messaging around that, I think it's actually really interesting to see that those of us using claims, we're now getting the opposite, where within a system, we're getting higher rates like than originally when we were studying this. And so some way for us to combine forces, because the point that you made that I loved was like, the common misperception is that people think children are healthy. And so we have a system perfectly designed to think kids are healthy and not focused on. And so I wonder if there's a way, to your point of like, we're not getting the system to engage, if there's a way for us to start to combine data a little bit more in terms of the story, because it might be a way to get those people that were like, oh, it's just a survey. And you're like, no, these are actually similar themes, and there's similar points depending upon how you look at it. So I just wonder if that's an opportunity later on, given a lot of our IP states are thinking about that.
So I'll say very quickly that I think yes, and I can tell you that we actually have somebody on detail from the National Center for Health Statistics working with us for about 1.5 years, really diving into the screener, because we do know that even within the national survey, there's like 40% of kids who have conditions like named conditions, diagnosed conditions, their parents don't endorse the items on the screener. Now, maybe that's okay in the sense that we were trying to get at impacts and not necessarily diagnose conditions. But I find it hard to believe that it's that disconsonant. So we're doing some look at that. We're working with the new special healthcare needs director to kind of think through, like, what do we want to do with that? Because you can also imagine there's really big implications if the Bureau is suddenly like, hey, we're changing our definition of special healthcare needs. So we're thinking through that, as well as the concept of the at-risk population, because we know that that has never been operationalized. So what started out as, like, we thought like a 3-month analytic program or project for this intern has now turned into literally 1.5 years, and she's still going. So yes, lots more on that. I don't get to make that call, but we are digging into it.
Great. Well, thank you so much for your time. And as you can see, there's a lot of interest in the data and trying to figure out how we can measure what's happening with kids. We need to move on, but I wanted to, again, thank you for taking time to prepare that excellent presentation and share your expertise with us. I am going to flip over to Rachel to give us some instructions about where we're going next.
All right, thank you. So we're gonna go into breakout groups. We have one group that's going to be talking about pediatric measures, past and present. So if you're interested in kind of continuing the discussion that's going on now, you can potentially do that in that group, and Brina Holmes will be facilitating that. And then we have another group that's going to be focusing on mental health and talking about what are those really effective strategies to help primary care clinicians address mental health in their youth. And Rebecca Nevdale from Frameshift will be facilitating that.
All right. Think we are back. I see lots of faces popping up. So I know that time went fast for us in the group I was in, and I'm sure it went fast for the other group as well. So we'll try to do a quick report out and then also have some time for some discussion sort of across groups as well. Selfishly, because I was in Brina's group, I'm going to ask Rebecca's group to go first. So maybe a quick report out on kind of what you guys talked about, and any major themes would be great.
Sure. So I actually kept notes, so I'll share I will share a link in the chat here for people if you all want to log on. So we didn't have enough time. So, but we did get to hear from 1, 2, 3, 4, 5, about 6 different states. There's lots of different topics that we were talking about. What have folks done to help practices focus on mental health? So what projects do we already have in process? And then what are things that we've done in the past? And because our coaches meet monthly, we can actually take all of this information that we learned, that we heard about, and then this is like fodder for us, whatever the right word is, for future calls. So Utah has gone through a process over the last number of years, going from screening to referral and communication between PCPs and behavioral health. And now they're entering how do we look upstream for behavioral health, which is really exciting. And then a couple people mentioned, hey, med management is really huge. Like, as you continue to offer mental health kinds of projects, behavioral health kinds of projects for your practices, beware, medication management is really big. Another thing that really jumped up to me was on this project models side. A lot of folks saw a greater need for training and education of their practices than they had maybe anticipated, it sounded like, at the onset. But people are really hungry for education about this topic. Oregon's doing some stuff with our younger kids, which turned into a performance metric for their CCOs on integrated behavioral health. So Alex was very excited about that, as I'm sure others are. We're always excited to hear about what happens in Oregon magically that can never happen in our states yet. So, and And partners, I think we talked a little bit about Project Aware, which is, I guess, and I thought it was an Arizona thing. So apparently it's not, it's a national model connecting primary care, behavioral health, and school districts together to help better support kids. The importance of building relationships over time and like staying front and center of those people. The role that Medicaid could play kind of popped up and went away. So that's what we talked about. That was a really bad summary, but it's all here. And you can click around and look at our notes. So if anybody has anything else to add, go for it.
Thank you. That is amazing. I'm not familiar with that software. It's super helpful. Anyone else from that group want to add anything before we turn to Brina? Okay, we'll have more opportunity later if you want to think about it for a few minutes. So, Brina.
Sorry, this is Nicolene. I'm sorry,
ahead.
I couldn't unmute myself. So the Frameshift group facilitates the monthly NIPN coaches calls. So I'll put in the chat my email if those of you would like to, new folks would like to join, just send me an email and I'll send you an invite.
Great, thanks. Now to you, Brina.
Okay, so our group, we wondered about social emotional measurement and wondering if states were figuring out a way to measure strengths or family engagement, relationships, protective factors. Turns out no one's really making a lot of progress in that space. We did discuss the Strengthening Families framework from the Center for the Study of Social Policy, and Wendy and Pat appropriately wonder if those 5 protective factors, which we can share with the group, have been, are we thinking about them differently now in the context of families, race, and a growing understanding that how we define protective factors is probably outdated. So I thought that was one of the more valuable sort of frames for me as we think about what Vermont's trying to do in this space. Unfortunately, Arizona had not much. Peggy noted there, it's really more about the clinical outcomes, and Rhode Island, Pat noted, they measure a fair amount of deficit, not so much what's going well. And then we had a wonderful conversation with Colleen in Oregon about metrics and money, and sort of picked up on the end of Dr. Gandour's talk about how that having all that data in the absence of the connection to the Medicaid and the national leaders and really changing the way we deliver care or get paid for care is felt a little disheartening. So but we'll end on a positive note to say that we felt that it may be time to really work together to incentivize the efforts to work in a relationship-based way with families, including dyadic work, as we all struggle to do. How do we get more focus on the adults surrounding the children we're caring for? So I will stop there in the interest of time. What others from the group? It's a lot to summarize in a fast-paced 20 minutes.
That was excellent. So we have a few minutes for kind of cross-group discussion, questions, additional comments that people want to make, or even continuing discussion from the previous session. Anyone want to chime in?
Well, I think one of the things that's unique about NIPN is that because we're partnerships, sorry, I've been just sitting here coughing on something I inhaled. We're working across systems. So we're really interested in the kinds of outcomes that no specific system can own. One of the things that we heard in our breakout is how any given system, like Colleen was talking specifically about the behavioral health global budget for, for kids, and how that gets in the way of actually really taking care of kids. Because if you spend money on the ones that are really sick, my, oh my, do you lose it out of your own pocket or out of your ability to kind of do other things that you're supposed to also be doing on that global budget. But if you think about just early childhood, there's a lot of systems that have to work well together to make a difference. And one of the things that maybe we can do, we're never going to get a good answer, but still you can put a stake in the ground, is to say, we need those cross-system measurements that, we know families have we have to affect family behavior as well. We're never going to get 100% on those measures. We might be lucky we get, 10%, but something that says there takes a lot of factors to get something right, but we have to look at what's an outcome. What is the actual outcome we're trying to achieve? And then think about all of the complexity that goes into that. And it's really scary for people. We tried that with an early childhood initiative with 5-6 state agencies, and they all loved the idea until it came down to, what does it mean for me? In which case they got really scared and backed out.
It's a great point. Yeah, I think thinking through, feeling this tension that we're all a little bit still here, providing these basic supports on everything, the practices are saying we don't know where to start, and then we also need to be up here thinking about how do we elevate these systems levels issues. And it's a big tension I know a lot of us are struggling with. Other final thoughts or comments before we break? Okay, well, with that, we are back on time. So we're going to break for 15 minutes. We're going to try to stick to that 15-minute time period because we have, for the second half, a pretty packed agenda as well. And are going to shift gears and talk about issues in DEI. So hopefully everyone can, as I tell my kids, get their yayas out and come back refreshed and ready to dive in. We'll see you on a bit. Hopefully people got a chance to refresh a little bit, answer some emails, and are recharged and ready for the next session. So we're going to shift gears a little bit and focus on another priority area, and one that's been, obviously an area of substantial attention and effort over the past few years. And I think a lot of us are in the position of trying to figure out, what do we do next in this space? So we're going to hear an overview from Wendy, and then use her presentation as the basis of our final breakout groups that we'll run into. So though she probably needs no introduction, I'm going to do it anyway and introduce Dr. Wendy Davis, who is Professor of Pediatrics Emerita at the Larner College of Medicine at the University of Vermont. Where until very recently, she was the senior faculty at the Vermont Child Health Improvement Program and one of the co-directors of NIPN, as most of you know. She has held multiple positions in pediatrics and public health. Her resume is very long, so I'll highlight a few. Lecturer and instructor in pediatrics at Yale University, attending physician at the University of Vermont Medical Center, Director of Maternal Child Health here at the Vermont Department of Health, the Health Commissioner for the state of Vermont, the EPSDT Program Chief, the President of the Vermont chapter of the American Academy of Pediatrics, and a member of the Board of Directors as the District 1 Chairperson for the AAP. And notably, Dr. Davis recently chaired the AAP Board of Directors Committee on Equity that produced the AAP statement against race-based medicine. So for all of that very deep wealth of knowledge, we've invited here today to share some thoughts with us on that. So I'll turn it over to you, Wendy.
Thank you so much, Rachel, for that lovely introduction. And actually, it just struck me, I want to call out something about one of our colleagues on this call, because my role as the District 1 Chairperson for the American Academy of Pediatrics is about to come to a close at the end of December. But we have in our midst Dr. Pat Flanagan from Providence, Rhode Island, who is the new District 1 Chairperson. So congratulations, Pat. I could not be more thrilled that you are taking over in this role, and you are going to be fabulous. So I'm so excited that you are joining us here today. And thanks, Rachel Wallace-Brodeur has agreed to advance my slides. I will just say quickly, I think the advertised title for my talk was something like anti-racism and QI. I reshaped it a little bit based on some feedback, which I will share with you, but we're going to talk about advancing health equity through quality improvement. Next slide. I wanted to start on an up note, and I was so it was fun to see that poll that Rachel posed at the very beginning about football versus soccer, or I shouldn't say versus, I guess, but and I actually put in the NFL. I didn't put in soccer, but I think we sort of can't help but have been captivated a bit by what our U.S. men's national team has been doing over the past week or so. In particular, if you have not seen this interview with Tyler Adams, who is the 23-year-old captain of the team and did a press interview a couple of days ago. I'll look at the screen, raise your hand if you saw it, but it was astounding. He was interviewed by an Iranian journalist who asked him about how he felt about representing the U.S. with our history of discrimination. And he said, we've followed the Black Lives Matter movement from around the world. And he called Tyler out on his mispronunciation of his country and said, we are Iran, not Iran. And so the response, again, you just have to pull up this clip, but I'll share a few pieces of the response. He said, there's discrimination everywhere you go. One thing that I've learned, especially from living abroad in the past years and having to fit into different cultures, is that in the US, we're continuing to make progress every single day. By the way, he started his remarks with an apology for the mispronunciation, just so astonishingly gracious. But he ended by saying, it's a process. And I think as long as you see progress, that's the most important thing. And that really struck me in terms of what we're talking about today. Rachel, you can go to the next slide, because we actually, and I appreciate the planning group's willingness to do this, we sought some feedback from many of you on this call who are leaders in your organizations to identify what would be most useful about this presentation. And here's what we heard. Many of you said things like, we understand the scope of this problem, and we really want a focus on action steps and how we apply this in our work. And I'm going to give you some definitions in a moment of what I think we're talking about when we say this problem. I'm going to just challenge this assumption a little bit by saying, I think I know what people are saying. They didn't want a half an hour of data about the health disparities and inequities that we know are rife across our systems. But I also think we can get a little complacent about believing that we really understand the scope of the problem. And I'll say a quick example of that. When we embarked after fashioning the American Academy of Pediatrics position on eliminating race-based medicine, we set ourselves a goal of saying, we're going to review the entire catalog of policy statements and clinical practice guidelines and technical reports, and really all of the content that the Academy publishes. And, when we started looking, the numbers are astounding, and we had to quickly get to a strategy, I guess I'll say, that made that task manageable. But my point about that is, I think you don't really know until you continue to dig deeper and deeper. So let's do that together. You asked, how do we break this huge problem into smaller actionable steps to affect the system? And people asked, where's the key driver diagram? Good for you. Yep, we need to stick to our traditional tools. And what's the best way for IPs to use race, ethnicity, and other demographic data of which we become more aware in recent years? And you identified barriers to that, such as worrying about interpretations that would lead to blame versus calling out the systemic issues, lack of trust and accuracy of practice data, small denominators, reluctance to disclose information, all data issues that we struggle with every day. And then folks also were interested in some guidance about how improvement partnerships could inventory and address our own implicit biases and how they impact how we function in our work. Next slide. So with that, these are the objectives that we agreed upon. I'm just going to quickly walk through and be very mindful of our time, a framework for breaking this problem into actionable steps. And I'll give you a little bit of my take on a key driver diagram. We're going to consider together a race-conscious approach to QI measurement frameworks and data collection. And then I'll close by just identifying some ways to inventory and begin to address those organizational and individual biases and really think about us as IPs continuing, I will say, on our journey to becoming anti-racist multicultural organizations. Next slide. I did want to just to level set, quickly share a few definitions. Let me on this slide just highlight health equity as the state in which everyone has a fair and just opportunity to attain their highest level of health. Achieving this requires ongoing societal efforts to address historical and contemporary injustices, overcome economic, social, and other obstacles to health and health care, and eliminate preventable health disparities. And this requires, of course, attention to the systems and policies that have given rise to where we are today. Next slide. Also wanted to just call out social determinants of or social contributors to health. And this part of the framework comes from the Centers for Disease Control and Prevention. But again, really a definition for social determinants, which you all work within your IPs every day, I know. And the CDC calls out the 6 key areas that you see on this slide. So again, just kind of a level setting, ground setting set of information. Next slide. And then these might be a little bit newer, but when we talk about race-based medicine, what I mean by that, and with all of these definitions, by the way, I should have said, you know, these definitions certainly vary across organizations and groups. I'm only presenting them so you have a little bit of an insight into where my head is at on these, but you may have your own or preferred definitions. And really what's most important is when we're talking with our the folks that we collaborate with and serve, how are they viewing these different terms as well? But race-based medicine is really, when we wrote that paper, talking about the inappropriate use of race as a corrective, risk-adjusting or dichotomizing variable in algorithms, practice guidelines, or policies that influence the clinical decision-making process. And I really want to emphasize that piece about the inappropriate use. What we are moving to, we think, in 2022 is focusing on or thinking about race-conscious medicine, which is an approach that emphasizes racism rather than that dichotomous variable of race as a key determinant of illness and health, and encourages us to focus only on the most relevant data to mitigate health inequities. And then finally, anti-racism. And, you know, for many years now, we've been talking about diversity, equity, and inclusion, but really what's come into focus more recently, I would say, is anti-racism, or the active process of identifying and challenging racism by changing systems, organizational structures, policies, practices, and attitudes to redistribute power, and that's an important element here, and resources in an equitable manner. So now we're beginning to talk about diversity, equity, inclusion, and anti-racism, or DEIA. Next slide. Quickly, a few of my own personal guiding principles about this. And I want to start by saying we're all learning. This is not easy content, but it may not be as overwhelming as you think. I hope to convince you of that. I also want to very quickly say I am not an expert and I don't pretend to have all the answers, any of the answers really. But I increasingly am taking joy from the colleagues that I work with and from whose work I can learn, amplify, and support. And hopefully you are finding that as well. We have a lot of work to do, and I think we sometimes get a little stuck at the where do we begin. And so I'm going to try to share with you what are just some of my thoughts about that, and address how we can think about our biases, raise our awareness, and expand our networks. And also, I think it's really important to say we are all in different places on this, both individual and collective journey as organizations. And so I apologize in advance if for some of you this is very, very basic, or maybe for some of you this is new content. But I think the bottom line is hopefully we can sort of respect where each other is on their journeys. Next slide. And then I also want to share some principles from the American Academy of Pediatrics, and I'm not going to go through all of these again in the interest of time, but I think there are a few of these which form the basis of the AAP's equity agenda and how they are approaching their work may be good for us to hopefully come to consensus about. So I hope that we can all agree that all children and adolescents have equitable health care within a medical home that includes primary care, subspecialty services, emergency medical services, and hospital care. And that as child health professionals, we can address the social, behavioral, and environmental factors that affect children's health, development, and achievement. Next slide. And then I'll just pull out a couple more. And again, you can find these. I have the link to the AAP's equity agenda at the bottom here, and it really is nicely designed to show you the agenda itself, the principles upon which it's based, and a very thorough work plan about how the Academy is approaching its work. So you may find that helpful. But again, really, I think hopefully we're all advocating for the identification and elimination of racist policies and inequities that contribute to racial disparities and impede equity. And we want our workforce to be diverse and reflective of the child population. And I think these are important because they're lofty principles. And again, sometimes we can get a little stuck in saying, well, what can I do to eliminate racist policies? But I hope to show you some of that next. So this framework, and I'll just point out this graphic because I like this. This is from a group called smarterandharder.com. But, you know, here we are, the tiny blue figure, and the big purple figure is our problem. And that's what it feels like. But this group likes to talk about breaking problems down into little tiny problemitos. So no longer do we have one big problem. We have many little problemitos, and you can pick and choose the problemito that you want to work on today or tomorrow. So that's where we're going to go first. Next slide. And the framework I'm going to share is from the Institute for Healthcare Improvement. Many of you may be familiar with this. The IHI really started very formally embarking on this work a number of years ago. They published in 2016 a white paper called Achieving Health Equity, a Guide for Healthcare Organizations. And then they very quickly established a series of learning network and action communities on equity and racial justice in healthcare. And their focus really here was healthcare organizations, and the goal was to accelerate the role of healthcare and organizations in improving equity. But I really think the principles and the components here are things that we can adapt. I mean, we are healthcare organizations. We don't all deliver healthcare directly, but we support those who do. So I hope you'll find that this works a little bit for you. And I will also say this is like any model that we use in QI, right? I mean, you may have other frameworks or models. The CDC has a framework. Robert Wood Johnson Foundation has a framework. So you may have already identified and adopted a model that works well for you, but if not, maybe this is something that you can adapt for your own use. Next slide. And so there are 5 framework components here. You see them here: making equity a strategic priority, building infrastructure, addressing multiple determinants of health, eliminating racism and other forms of oppression, and partnering with community to improve health equity. And the IHI has pretty robust guides for each of these components, pretty accessible on their website if you know how to join them. And they also have a tool that I'm going to show you a little bit about in a few moments, an assessment tool for healthcare organizations to really try to identify and understand where you might be on a continuum of becoming an anti-racist and a multicultural organization. And then finally, there are some case studies and team reports that you can review, which may give you some ideas for specific strategies. Next slide. But I do want to, I'm going to share what is my beginning of a health equity key driver diagram. And again, some of you may be way ahead of me on this. I didn't, in researching this, really find anything that seemed to fit our collective needs as improvement partnerships perfectly. But, you know, again, this is where I think sometimes we just have to jump in feet first and revert to the tools and methods that we know and try to adapt this content to sort of align with the tools and methods that we know. So I will be the first to say my aim on the left, which is building our improvement partnership capacity to advance and sustain health equity for the patients, families, colleagues, and community partners that we serve, is not a smart aim. You guys can assign some numbers and timeframes to that, but again, it's a place to start. And then I inserted as the primary drivers really pretty much those 5 key components from the IHI framework. And so then if we work backwards to the secondary drivers, and I'll certainly make these slides and templates available if people are interested in following through on this. But just as an example, if we take that top primary driver of health equity as a strategic priority, as a secondary driver, we can think about including that in our strategic plans and specifying in our goals and objectives. Senior leadership, ownership, and commitment is really key here, as with many things that we do. When we talk about infrastructure, we need to think about our data infrastructure, our ongoing personal and professional development, and think about our workforce and hiring practices and whether they're really designed to optimize the diversity of our workforce. And then addressing multiple determinants of health. And again, I apologize because I'm sure you can't see this very well, but that's really about prioritizing social determinants or social contributors to health as we select content for the improvement work that we're doing. So I'm going to just flip on to the next slide. I hope we can come back maybe in the discussion and talk a little bit about that framework and that key driver diagram. I'd love thoughts about whether you've already embarked on fleshing something out that's more robust, or whether these resonate with you and you see yourselves potentially being able to use them. But let's just talk a little bit about that race-conscious approach to QI measurement framework and data collection. And I think this is one, again, I really love Dr. Gandour's talk, and where she was able to bring in how the Bureau is using race and ethnicity. But I think, again, this really starts with having an awareness of needing to do that, and then thinking about what are the optimal ways to build this into our measurement activities. So next slide. So this is where I think the Academy, if you haven't done this, I would encourage you to travel back in time, and you don't have to go too far back, just go back to July of 2019. But that initial policy statement from the AAP on the impact of racism on child and adolescent health. And if you look at the upper left-hand corner of this slide and see that statement, and then follow it around in a counterclockwise direction to 3 years later in July of 2022, what we did was really set out on a pretty deliberate trajectory to describe the problem, and then to think about where we were seeing evidence of race-based medicine having crept into how we were designing our clinical practice guidelines and our algorithms, how we were testing them, how we were evaluating them. That led in May of 2021 to retirement, actually, of the original clinical practice guideline for urinary tract infection, having identified race in that guideline as an inappropriate variable for classification. That moved us to move back out and be a little bit more general in now describing that whole perspective of race-based medicine. And then finally, just this past July, to publishing the policy statement on eliminating race-based medicine. So I think, this is an example of doing a bit of research, really beginning to try and describe the problem, and then embarking on a journey where you very intentionally and sequentially take the steps to get you to the outcome that you're seeking. And of course, we're not done with this work. As I said, we now have that catalog of hundreds of publications, if not thousands, that need to be reviewed. But just an example, and you may think about how you could do something like this in your own organization. Next slide. There was an article actually that preceded our race-based medicine article in pediatrics that was in the Lancet Open Access Journal a few years ago. And that was the commentary from race-based medicine to race-conscious medicine, how anti-racist uprisings call us to act. And of course, that really came out in the wake of some of the events of the spring of 2020. And this was people really beginning to talk in the public space of healthcare about how hypotheses that involve race are frequently implicit and circular, and rely on conventional wisdom that Black and brown people are genetically distinct from white people. And this group of authors called out the harm and the harm really that was being inflicted by this approach, and called for us thinking about race-conscious medicine as a new approach. Next slide. And so again, lots of discussion in the medical literature over the next couple of years leading to that AAP policy statement, which really, again, if you haven't read it, take a look. This is where you will find the history and some really striking examples of how this has been woven into the fabric of our healthcare delivery, our research, and really so much of what we do every day, and calling out the need to eliminate this as a biologic proxy. Next slide. And so when we think about improving data collection, and again, I'm anxious to talk about this in our breakout group, you, as I noted at the beginning, you've called out what you see as some of the barriers to using race and ethnicity data in your IP measurement frameworks, but really the world has moved to thinking about what is variably described, for example, as the real framework, so race, ethnicity, and language. And of course, if we think more broadly, we would expand this to include characteristics like gender identity, sexual orientation, religion, disability, as Dr. Gandor showed us today, socioeconomic status. The United States core data for interoperability, interestingly, has moved fairly quickly through their last few iterations, version 3.0 and soon to be upon us version 4.0, by continuously trying to add data elements that will help us explore these areas of inequity and disparities, and with a very specific, again, intent to say we want to identify healthcare disparities and understand why they're happening. And so some of the later added elements are things like social determinants of health, and they just added in that last version a new data class of health insurance information so that they could explore how that might be impacting healthcare disparities. Next slide. And then again, there are lots of folks writing and publishing about this, but what you might consider in your IPs is what some institutions have done by creating health equity dashboards. And this was an interesting example from the University of Michigan, where these folks created a dashboard, and actually this appeared in the journal Academic Emergency Medicine, and I was pleased to see that this group was really focusing on trying to set up a system that would help their learners, their medical students, their residents, their fellows, think about these variables in how care was being provided in their emergency department. And so they created an equity dashboard that allows them, again, to explore disparities in care and outcomes. And I've listed the reference here. This, again, if you want to think about setting something up like this as an IP, would be a great place to start. They've sort of done the digging and the work to think about what the data elements need to be. And they have some really terrific examples in this article of how to cut the data in order to make it useful for understanding disparities in care provision. Next slide. And then just, I would encourage us all to continue to think about, and again, I know some of you are doing this already, but including in your data collection frameworks, integrating geographical data. And I would just say that the CDC Places Initiative, which is a collaboration among them, the Robert Wood Johnson Foundation, and their own CDC Foundation, is a place where you can find terrific data that is cut by very small areas across the US that allows you to examine the impact of geography on some of these variables. Next slide. So I know I'm getting close to time, so we're going to wrap up and just talk a little bit about some ways to inventory and hopefully begin to address your own organizational individual biases. And then I'm going to give you my examples and thoughts about what can you do when you go back home or back to the office tomorrow. What can you do by next Tuesday? So next slide. I'm going to take us back for a minute to the IHI, because they have actually quite a robust organizational assessment tool. And what this does, again, easily accessible on their website at that link that I showed you earlier. They take each of those 5 framework components, and they've created numerous elements for each of the components, which you can score yourself on a scale of 1 to 5, or you can say you do not know, to rate your level of progress. And they give some examples of different ways to use this organizational assessment tool. But just, as an example, they encourage you to have different individuals complete the tool and then get together and talk about what's the variation look like and why is there variation. So that's an approach that's very near and dear to us in QI. And for elements which you've rated yourself as low, what would it take to raise them? And you can see just one example under the strategic priority component. One of the elements is we are building staff awareness, will, and skills to improve health equity. And they encourage you to really be specific in capturing how you're doing that, and then again, revisiting in the future whether you've made progress. Next slide. There's a much more robust organizational assessment tool, which we don't have time to go into, but I really like this one. And this really comes out of community organizing work in a group in Chicago. But this gets much more granular about the evolution from a monocultural organization to an anti-racist multicultural organization as you move across the page here with, again, some very specific strategies for you to think about. We were asked to think about this and discuss it as a group at a recent AAP board meeting. And it was very helpful because it pulled out, first of all, lots of differences in where we thought we were at, but then also the opportunity to agree upon next action steps in order to improve our performance. Next slide, sorry. And then, really at the individual level, thinking about, and again, I suspect many of you have done this in your groups, but consider completing some of those unconscious bias awareness trainings and evaluations, and then talking about those as a group. And Project Implicit that comes out of Harvard obviously has tremendous materials here. And the AAMC also has an approach to this. Next slide. I'm going to skip over. I think I have a few more things about individual biases, but I want to keep us on time. So just know that there are lots of resources. If you want to go, back to your group next Tuesday and say, we're going to just tackle one of these diversity and inclusion group activities or team building activities today, let's do it. And there's some good guides for how to approach that. Next slide. And this next is a graphic of something that supports one of those activities. I'm happy to talk about that in the breakout if it's of interest. Next slide. Just a reminder, let's just go through a few of what I think you can do by next Tuesday. So under each of these components, and I'll just maybe call out one under each. So under making equity a strategic priority, do you have an organizational strategic plan? Is equity visible in it? If not, why not, and how can you get there? Building infrastructure, make this topic area, DEIA, a part of every staff meeting, every team meeting, every project meeting, every time you meet with your advisory groups. And then create and monitor opportunities for professional development so that you can all come along together in learning in this space. We talked about the measurement framework. Next slide. Addressing multiple determinants of health. Again, I think many of you are already doing this in your projects, but really broadening the focus from some of our more traditional aspects of healthcare delivery to thinking about what can we do to support practices in identifying social needs, and also what can we do in our communities to help impact the availability of services for our patients and families. Eliminating racism and other forms of oppression, and I think this is one where we get stuck because it's so big. But you can start with, having read that race-based medicine paper from the AAP, just every time you begin to set up a project, think about screening every algorithm, every clinical practice guideline, a policy, a practice that you are promulgating among your members for elements of race-based medicine. You may or may not find them, but it's worth taking a step back to look. And then partnering with community, really inviting participation from those partners, identifying new and less traditional partners perhaps, and really creating very intentional opportunities for learning. Next slide. Rachel, I'm going to skip over the next two because these were just reminders, so you can go to the one after this. But Bright Futures is on track to incorporate elements of diversity, equity, inclusion, and anti-racism in their next iteration. And they're not waiting for the next published book. Many of you may have seen that they recently had come out with an opportunity for public comment on ways that they want to embed this. And this is in alignment with some of the recent changes to the periodicity schedule, in which they specifically called out in a footnote the need to incorporate this content. So I'm going to close. Thanks. We can go back to Ibram Kendi here and his wonderful book, Anti-Racist Baby. These are some of the other guiding principles that I think we can all take with us. I love this book, and it's a children's book, but honestly, if you look at the words on this slide, you will see these are really things that we all need to be and could be doing every day, both internally in our teams and with our staff, but also as we work with community partners and patients and families. And I think on my last slide, I just had a couple of my thoughts. Next slide, about things you might want to think about in the breakout groups. You can go back, Rachel, to that. Yep. And Rachel, I think you have a slide also with some prompts for what you were hoping folks would think about during our groups. But that's my content. It was a bit of a quick run, but I hope you saw some things that might resonate with you and prompt some discussion. And just thanks so much for being here today.
Thank you so much, Wendy. That was just chock full of information and obviously a lot for us to mull over as we're going into breakout groups. I really appreciate you taking the time to pull all that into. I know there's so much in this space, so it must have been challenging to figure out how to get through it in half an hour. I appreciate it. I am going to flip to Rachel, who's going to give us instructions for the next breakout group.
Yeah, thank you. So we're going to break out into 4 groups. You're going to be randomly slotted to that group. We're going to take some time, just a small group, to really talk about what we just heard from Wendy. And we're going to use the 3 what's framework to really help guide our conversation. So, you know, we titled this Now What? How can we take action? What can IPs do both internally and with our practices, partners, and others to address racism and health inequities? So we're going to first have you think about what. So really some of those questions Wendy just shared, but what did you hear? What information stood out? What kind of shocked you? And then we'll think together about, so what? So why is that important? What patterns or conclusions are emerging, you know, as you discuss as the group? And then lastly, now what? So what actions make sense based on what we've heard and the discussion that's happening? So we'll have about 20 minutes for this, and then we'll come back for the full group to really share out what each group came up with.
But hopefully that was a really interesting discussion. And I know in my group, we had a lot of things to chew over. So I will start with Christy G, who's reporting out from your group.
I'm going to report out for the group, but certainly, team, if I leave anything out, please let me know. Hi, everyone. I think it was a lot of us sitting with kind of the enormity and feeling like a lot of how we could process and how we could work our way through all the different components, and really focusing on really 3 kind of levels. One of that internal examination for ourselves, and then where our organization is, and then where the organizations or practices that we work with. And thinking also a lot about how we're bringing equitable voice into the work that we're doing and the strategies for doing that, what that looks like, and how we can reevaluate to ensure that we have the voices that need to be heard there at the table. We also talked a little bit about some of the pieces that we found to be really helpful. So in terms of the dashboard, there was a lot of energy and excitement around diving into the key driver diagram, and some of the other great resources that Dr. Davis shared. And then also that challenge and opportunity of making time and space to do the work for ourselves and for our teams, and strategizing around what that could look like. Yeah. So, thank you.
Great, thank you. Next group, we'll turn to Rachel. Do you want to report out or tell us who from your group is reporting out?
Yeah, I'll report out and then my group can chime in. We discussed really how this work is a process and how interesting it was to see how kind of even in Wendy's examples, how the discussion has transitioned, and it's a process for all of us. And I think several people mentioned that, you know, feel like we're just scratching the surface, that this is still an add-on versus fully integrated into everything we do, that it doesn't really feel, yeah, it just doesn't feel genuine because it is still that add-on versus integrated. There was talk about really the need to address this both at an individual level, but as an organization, as IPs, because it feels a little false to be doing some work externally or kind of supporting this work if we haven't done it ourselves. Really addressed these systemic issues and think about our own biases and how we do our work. But really, you know, some more concrete stuff is really the importance of making that sure that diverse voices are involved in our work. So whether it be, you know, family councils or community councils with diverse representation. So that is part of our work. And I think that's mostly it. We talked a little bit about data challenges and with small data size, how challenging it is to really meaningfully use data in our QI work. But yeah, I think that's the crux of what we talked about.
Thank you. Brina, I think your group is up next.
Yeah, we didn't talk about who was going to report out. Does anyone want to? We had a great conversation. I loved my group, and it feels like it's 8 o'clock at night here. It's so dark. First of all, Wendy, really good feedback about the frame, that people really appreciated the different levels and the structure of it is very helpful, because you can just start, like in Oregon, Lydia shared, they looked at their mission and tried to get the language right in their mission. And they've added equity to their monthly meeting agenda. And then when it comes up, it has some variability in what they do with that, but the word is on the agenda, which is lovely. And then Amy shared with us a state experience. She had moved. I'm not going to call out the state she left, but the new state she finds herself working in has more attention to this space and actually has the data to think about race, which other state didn't even stratify by. So that conversation about what you don't know and whether you choose to look, and then we spent a little bit of time, Mary and I acknowledged our age and that we like that our adult children call out language all the time with us. And my example from Thanksgiving was an uncle referred to the people in the kitchen as slaving away. Pretty common verb 50 years ago, horrifying. And all three of my children said, you're not, stop, like called out the uncle in front of 20 people, which is bystander work that we really need to do. And then Rebecca was wonderfully open about efforts that stall when people leave, or if you make some progress and then sometimes it just stops happening. Like you do a land use acknowledgement and then the next group of people just don't. And how do it's like it's a fad or something, and that we would really rather all of these important changes be solid and solidified. So thoughts from our group, we went all over the place as we needed to, because we feel that we created safe space to just try. And I appreciated the conversation very much. That sum it up, team. I could have used another hour with this. If you guys do breakouts again next time, I want my same group.
Excellent. Well, we similarly forgot to assign a reporter until the last 60-second thing jumped up. So I'm going to do my best to pull things from the notes I took and lean heavily on some of the other folks who are in that group to fill in some of the detail that I'm leaving out. I think we, like a lot of other groups, kind of one of the main things we were feeling like we were taking away was the just start piece of things, that there's a lot of work done already. There's great resources available. You can feel lost in those resources, but at a certain point, just dive in, and doing a little something is a good start to things. And so trying to pull that out of Wendy's presentation and then talk about some of the little things that people are doing in that space. I'm going to turn to Peggy in just a second to talk about something on the data side, because we had a fair amount of time spent talking about the challenges of data collection in this space, that there's, a push to collect data, but there is no good data. And there's, it can't really happen that easily as just saying like collect data and analyze data, that doesn't necessarily happen that easily. And then we talked a little bit about sort of the structure of us as improvement partnerships, kind of where we're sitting in this space relative to other initiatives going on in our state, and also the need to kind of, as other folks were saying, like build in some infrastructure for this, some of the challenges of doing that in our day-to-day work, but also how if you start to build it in a little way, it can kind of, snowball into the next thing happening and the next thing happening. So some acknowledgement of kind of the need to do that and some of the challenges of doing that with the resources that we as organizations have right now. Peggy, do you want to kind of chime in on some of the data pieces that you were telling the group about?
Sure. So we do a lot of work that's like 2 arms lengths from the practices, but we're working with a group of folks that are working with federally qualified health centers on oral health integration. And one of the things that they're supposed to do for the money that they get is think about equity. Like, how can you make sure that these services are received in an equitable manner? And everybody, of course, you start to ask about it. Everybody's all for it, but okay, then I'm stuck. What do I actually do? And a lot of analysis paralysis. But one person recently shared, she's like, well, we just have to do something. So we've gotten them pretty good on hitting their metrics, whatever, for what we're trying to do. So we started to look at, you can't take care of people that don't walk through the door. And, they are an FQ, so they have to make some attempt at, race ethnicity data. And they looked to see, they looked actually more at a panel management piece. So looked to see who was not attending their well visits. And, looking back over a couple of years to see, and we're able to identify, that was actually overall, they were doing pretty well, maybe 10% of their panel that they weren't seeing for regular care. But when they then looked at, of that 10%, was there any variation there? They were able to say that there were different populations that were more likely not to come than others. And so that gave them something to put their hands on, just to say, well, if we're really looking at equity, we can't deliver equitable care if you don't actually come through the door. So let's start there. And it seemed like a manageable thing. So I thought that was kind of cool, as just how do you even start? And that was a cool way to say, we have data that can at least start us there.
Thanks.
Mhm.
So let's just open it up. We have, just a few more minutes left for this discussion. I know it's the end of the day. It is literally dark here in Vermont. So people may be feeling tired, but I know I'd love just folks to have the chance to kind of comment on what the other groups talked about, or share observations or thoughts that you haven't had a chance to yet.
I have one, I shared this with my group, but the one like kind of cautionary tale, because I'm on an organization that's been on the board of an organization that's been going through this, and our community justice committee, it has finally is made up of more people who are not white than people who are cisgender white people. And this idea of like giving ourselves forgiveness and recognizing that it's a process, I think is one that works really conveniently for white people like me. Just to like recognize our advancements, but I found in this group is incredibly frustrating to colleagues who have been marginalized over the years. So I look at our board and think of how hard we've worked to get a board that half of the people are not cisgender white. Like I see that as like this huge advancement, and they look at that board and see half of them are white. And that's all that they see, those people see. And it's been hard to like not be able to celebrate successes from my perspective, and to have to like take a step back and see that people are very frustrated and have spent an entire personal lifetime and career lifetime being marginalized. So just like a word of caution about that concept. So, because I think I've hurt feelings along the way by talking about baby steps being successes. So
That's a great point. Yeah. Sort of bearing in mind how you're perceived generally in life is good, but particularly in this space, I think is important. Other comments or reactions? Well, hopefully, some of the, Wendy, did you want to chime in? I just saw you come off.
Yeah, sorry. I just wanted to reflect to Rebecca. Thank you for sharing that. And I totally agree with and get the point. I will pull out the strength of that, which is because you were able to diversify your board, you were able to learn that, and you might not have seen that for months or years if you hadn't made the progress that you had. So even if you, sort of can't celebrate it or have to be mindful about how you respond, that is a win. It's to me. So thanks. I'm glad you shared that. Thanks.
Well, we are nearing the end of our time, and somehow when you look at the block of time on your calendar, it seemed like a really long meeting, and then it both flew by, but I'm sure you're all like me feeling a little bit tired because it is tiring to stay on Zoom. So I wanted to, first of all, just thank everyone for showing up, for continuing to be part of this network, for sharing your ideas and your thoughts, and hopefully the Zoom format was able to bring in, as I said earlier, people who otherwise couldn't have attended, and we'll, try to take a pulse about moving forward, whether it makes sense for us to continue this way or try to get in touch in person. I know a lot of us miss that kind of, chit chat over dinner and drinks, and not to mention the cookies. Thank you, Christy, that come with our in-person meetings. I had put in my notes for this part of the thing to kind of try to wrap up some highlights and themes for the day. And I'm finding I'm not quite sure where to start, but I think one thing that is striking me about the challenges that we face in the particular role is, and I mentioned this a little bit earlier, is we want to be up here. We have all these great systems ideas. We're the people who, we can kind of take this broad view, and we see the policies that are not working. We see, the payment things that aren't working, but we're also here on the ground. And we see the need for, just some basic steps of what's happening in a clinical encounter and what's happening in that practice setting. And trying to hold those two things can be really challenging in some ways, but it's also really unique to the role I think that a lot of us are playing. And it's personally for me what I find really rewarding. So I think that theme came up a fair amount in the different initiatives or the different conversations that we had today, both on data, thinking about how do we address data from the systems perspective, how do we address mental health from the systems perspective, and then, what does that mean for what we're actually doing? And then obviously this discussion we just had about DEI issues, or Wendy, I should say DEIA issues. and how we can try to make some progress there. I think, hopefully we'll have this ongoing learning together through the calls that we have throughout the year, and also the listserv and other ways that we can reach out to each other to provide support or advice or information. And so that's one of the goals too. Now you have a face to go with the name when you send that email asking, hey, how did you execute that thing? Can we jump on a call to try to connect about that? That said, I'm going to turn to the next steps. Rachel, are you pulling that up just so we can? Excellent. So just a couple of kind of things as we're wrapping up. As always, we have an evaluation and would appreciate it if folks could provide some feedback on what they thought worked and didn't work for both the format and the content. And we're happy to take that into account and really appreciate you taking the time to provide that feedback. Just to highlight some kind of ongoing activities that we have planned for 2023. For the learning sessions, we have those scheduled semi-monthly, so every other month throughout 2023, in which IPs can share their project work. And if you want to be included on the email list for those meeting dates and reminders, please email Christy Fay at the email address there, and she'll make sure that you're added to that. And then, as was mentioned earlier, the monthly coaches group and the contact information for getting added to that meeting is listed there. So one thing we did not have a chance to include today when we had to kind of shift from a multi-day to a shorter was a discussion of this group and what we want this group to be and how we can continue to be helpful to each other, a source of support. And so I just wanted to end by welcoming anyone to kind of reach out to me if you have thoughts, or anyone else on the team to share thoughts about, hey, it would be really helpful if the group could do X, Y, or Z, or, this is a waste of time, or whatever it is. Really would love to solicit that kind of information. I know you've done that in the past, and we may think of a way to draw that out of folks again moving forward. But as I'm relatively new to the group, I'm really excited to kind of solicit that information. So before I call it, just want to give anyone a final chance to chime in with any closing thoughts.
I think it came up a lot in the chat, but so nice to see y'all.
Yeah, we should probably retake the sheep scale at the end of the 3-hour Zoom to see how many people now have the bucket over their head.
And how many people are boinging, right?
That can replace the evaluation maybe next year. All right, well, normally we would say safe travels home, but safe commute home. Everyone enjoy your evening. And it was really a pleasure to connect with all of you. Thanks so much for your time.